right, hello everyone. This week we will be covering bacterial diseases in liver. So we'll be going over several different entities, and then some atypical mycobacterial infections are also included in this chapter. So first off, we're going to be starting with impetigo. So this is kind of a prototypical bacterial condition that we see more often in younger children. So here we see a subcorneal pustule. And what you'll notice is that the space of clefting is right beneath the granular layer. So here we have the stratum corneum, and then right through the granular layer, you'll notice a collection of neutrophils. And in this space, oftentimes what you'll see are clusters of bacteria. And you'll notice that there are degenerated neutrophils. But as we move around, you'll also start to see some acantholytic cells. So the epidermal cells are falling apart. But importantly, you don't notice any nuclear molding or any sort of viropathic change that you might see in HSV. You can see acantholysis though. And then the layer of splitting is similar to what you would see in pemphigus or some other conditions. But often what you'll find are clusters of the bacteria here. So the space of the split is important. So acantholysis with many, many neutrophils, and then often clusters of gram-positive cocci. So most commonly, we will see impetigo with Staph aureus or group A strep. And then the differential diagnosis for subcorneal pustules is, of course, Candida and tinea. You can also see subcorneal pustules with inflammatory conditions like psoriasis, pustular psoriasis, especially Reiter's, Snedden-Wilkinson, or IgA pemphigus. Those will often have a positive DIF in the case of IgA pemphigus. Drug eruptions, especially AGEP, and in that case, oftentimes we'll see some admixed eosinophils, and occasionally some dyskeratotic cells, which we're not seeing here. And then neonatal pustular dermatoses, including acropustulosis of infancy, neonatal pustular melanosis, and erythema toxicum neonatorum. Here, it looks like there is some solar elastosis in the dermis, so this is clearly not in an infant. So looking around at kind of the background of the age of the patient is helpful. So in this case, we have a subcorneal pustule, and I'll just go over to the Gram stain here so we can take a look at that. And in this case, we have the Gram stain. And looking in that similar area, the places that you want to look in the Gram stain are within the neutrophilic debris. And in this case, gram-positive is usually purple or blue. And these clusters here, these grape-like clusters, are clusters of gram-positive cocci. So in this case, most likely this is staph or group A strep. So this is an example of a subcorneal pustule with organisms. So this is an example of impetigo. Before we move on to the next case, I just wanted to review subcorneal pustular differential diagnosis. We talked a little bit about infectious things, but also in the realm of non-infectious entities, miliaria is something else that could present with pustule. And then just wanted to mention that in our differential. And then herpes, importantly, can present with a subcorneal pustule, but we talked about looking for viral cytopathic inclusions. So this next case is one that you could kind of miss easily. And I think one of the clues here, which is illustrated nicely in this piece, is where we're kind of losing this top layer here. So where this piece is falling off is a subtle clue here. And you can see this phenomenon in this entity, but you can also see this in other conditions. So what we have here is granular dyskeratosis. So this is kind of falling off and becoming detached right through the granular layer. So the plane of cleavage is right through the granular layer, and we see that there are dyskeratotic cells also in the granular layer. And if we zoom back in these areas, that granular layer and the stratum corneum are missing at the lateral edges of the biopsy. Here there's some extension in the superficial portions of the follicle, but you can see that it's not involving the deeper portions of the follicle. And there's relatively little inflammation associated with this process. Looking at the collagen here, this looks like this is a relatively young patient. So there's not much in the way of solar elastosis and a relatively paucity inflammatory infiltrate. When we go up to high power, in contrast to what we were seeing previously, where we saw many neutrophils and many organisms here, there's relatively little in the way of inflammation. So very sparse inflammation, dyskeratosis through the granular layer, a few dyskeratotic cells, maybe a neutrophil or two with some mild spongiosis in the epidermis. But other than that, not really much here. So there's two conditions really where we can see this pattern. And one is uh, staph scalded skin, or bullous impetigo, which is where you get this very thin cleavage plane and detachment of the epidermis. And in bullous impetigo, usually organisms are present, and that's a result of direct toxin production. Whereas staph scalded skin, there's a remote focus of toxin with a distant detachment of the epidermis. You can also see a similar plane of detachment in pemphigus foliaceus, and you would differentiate the two with a DIF if you were thinking that maybe this could be pemphigus. And the place of action of both of pemphigus foliaceus and staph scalded skin is more desmoglein 3, which is located more superficially in the epidermis, which is why we're seeing that detachment here. So staph scalded skin is usually in younger patients. Older patients and immune competent patients tend to have antibodies against that exfoliative toxin and can excrete it. But in younger patients, especially in younger children, they don't yet have antibodies. So they can develop these exfoliative, very thin bullae along with a high fever, and can rapidly kind of progress. And if you get frozen skin biopsies, you can differentiate that from EM, because you'll be able to see that only these thin superficial layers are detaching and the remainder of the epidermis is intact. Where if your differential was like EM or TEN or SJS, you would see full thickness epidermal necrosis with many, many dyskeratotic cells, and your epidermal damage would be much more full thickness with the basal layer and full thickness dyskeratotics. Whereas here with staph scalded skin, it's just very superficial that this plane of cleavage is occurring. And then also important to know for boards that Ritter's disease is the other name for staph scalded skin. Sometimes I'll ask eponyms. All right, the next case we have a bisected punch. And in this case, I'm just going to start with the unaffected half of the punch here for some clues for this diagnosis. So looking here, what we see is a perivascular infiltrate that is mixed. And you notice that around the vessels, what we have are a few neutrophils, and they are around the vessels and around the adnexal structures, and they're in somewhat of a vertical configuration, but otherwise not very exciting. So kind of like a perivascular infiltrate with a few scattered neutrophils. And in the setting of a pustular eruption or a presumed folliculitis, sometimes this is all you'll see is a sparse perivascular infiltrate, and sometimes it'll be oriented in somewhat of a vertical configuration. Occasionally you'll see the infiltrate surrounding adnexal structures, so maybe around a sebaceous lobule or around an erector pilus. In this case, in the other half, it's fairly obvious what's going on here. But sometimes in the initial sections, depending on whether your specimen is bisected or how far you've cut into the block, you may not find folliculitis on initial sections. And it's relatively common to have to cut many step sections to get into the center of the lesion. If you think about clinically taking a 4mm punch, usually your folliculitis is right at the center, and generally your biopsy is going to be bigger than your clinical lesion. So sometimes we don't always get that intersection. But here you can see very nicely that there is a hair follicle here at the center, and then surrounding that we have separative inflammation with degenerated neutrophilic material. And then here you can get maybe a sense of some pityrosporum or perhaps some bacteria. It's hard to tell what exactly is in here, but you can see some basophilic degenerated material. These I think are a bit too small to be pityrosporum, so probably some degenerate bacteria with an intact perikeratotic stratum corneum over top. And there is both intra, so within the follicular epithelium, neutrophilic inflammation, and also surrounding the follicle, we can see some neutrophils. Here, the follicular epithelium has been disrupted, and we have the beginnings of an abscess. So we have a little collection of neutrophilic material here with some degenerated neutrophils. And as we move away from the follicle, this transitions into a bit more of a mixed inflammatory infiltrate with some histiocytes, lymphocytes, and then even a few plasma cells here. So you can see this eccentric nucleus and a bit of more plasma cellular inflammation. Here we see some pale histiocytes with these open nuclei and what looks maybe more like a potato. So mixed inflammation. And depending on the age and stage of the lesion, you can get a varied inflammatory infiltrate. If you have a more robust inflammatory infiltrate that extends deeper into the dermis and even into the subcutis with abscess formation, then that would be more of a furuncle. So if you have deeper extension and abscess formation, it's not just a folliculitis. And folliculitis can be caused by both bacteria, including gram-positive and gram-negative organisms, more commonly like hot tub folliculitis for your gram-negative organisms, pityrosporum. We can also see folliculitis with fungi, tinea, and even viral infections. So herpes can be a cause of folliculitis, varicella zoster as well. And in those cases, you tend to see more necrosis of the follicular epithelium. And you can also see typical viral cytopathic changes, so nuclear molding, and typical changes like you would see in the epithelium. And you can also see sebaceous gland necrosis. So those are some clues to look for viral folliculitis. And then typically for these cases, we will check for both in the hair shaft and in the follicle special stains for microorganisms. So typically a PAS and a Gram stain. And then depending on the clinical setting, if there was suspicion for perhaps like a Meioki's granuloma or an AFB infection or something like that, if there's more of a granulomatous component, we might get a phyte stain or other special stains. Special stains are notoriously insensitive though, so culture is always helpful. If you do see pus clinically, you can either get a swab and send that off for culture, or if a patient isn't responding as you would expect to antimicrobial therapy, then sending off for fresh tissue culture or even PCR or other options to help manage your folliculitis. This next case is sort of a later stage in a similar spectrum of the same sort of lesion. But here you can see there's much more epidermal change and much more dermal change. So in the epidermis, there are changes that suggest chronicity. So we have epidermal acanthosis and hyperkeratosis. Here, even what looks like the beginnings of a stratum lucidum. And in the dermis, there's quite a bit of fibrosis with vertically oriented vessels and mixed lymphoplasma cellular inflammation. So these changes suggest scar and lichenification. So this is something that's been going on for longer. And this slide is courtesy of the University of Michigan virtual dermatopathology study set, which is an excellent resource with many derm path study slides. So if you haven't checked that out, they have a lot of really great derm path cases. And here in the dermis, in the superficial dermis, you can see that there's a mixed suppurative and granulomatous infiltrate. So centrally here, there's an area that's more granulation tissue-like with edema and many neutrophils. And as we move out peripherally, that transitions into more of a histiocytic inflammatory infiltrate with, again, neutrophils, degenerated debris, and many histiocytes with scattered plasma cells and lymphocytes. So here again, you can see that eccentric nucleus and sort of clock face nuclei and many histiocytes surrounding that. And here even some macrophages engulfing these neutrophils. So this is a later stage lesion. And with this fibrosis, this was a lesion from the scalp. And this is an example of what we might see in the setting of follicular occlusion triad. So these are lesions that begin with follicular hyperkeratosis, typically around the infundibulum. And this is what we might see with hidradenitis suppurativa, acne conglobata, and perifolliculitis capitis abscessans et suffodiens. And in earlier lesions, we have neutrophilic inflammation and abscess formation. And in later lesions, you get complete destruction of the follicular epithelium, which is what we have here. So this probably started around a hair follicle, like what we saw previously. And as the lesions progress, that follicular epithelium is completely destroyed. And these lesions can develop sinus tracts, and later you just get fibrosis and granulomatous inflammation. So more of a chronic inflammatory process. With these, typically we don't tend to see bacteria or fungus on culture. Often you'll get superficial skin flora, but usually you're not seeing much of an infectious process aside from commensal organisms in the dermis. But we do think there may be some sort of abnormal host response to normal flora or an increased inflammatory response in combination with that follicular hyperkeratosis that leads to these lesions. So antimicrobial therapy is still used both to decrease the load of organisms and perhaps for some anti-inflammatory properties in managing these lesions. But cysts, sinus tracts, kind of more of an exuberant folliculitis is what you would see here. More prominent follicular hyperkeratosis than what you might see in an ordinary folliculitis, but still lesions in a similar spectrum, and clinical pathologic correlation is important for making the diagnosis. All right, this next case is also courtesy of the University of Michigan virtual slide set. And this is an example of acute septicemia. And typically what we'll see here is a vasculitis with thrombosis, necrosis, and uh, vesiculopustule formation. So in contrast to what you might see with an ordinary leukocytoclastic vasculitis, here you might tend to see more dermal epidermal separation, more inflammation, more necrosis, more fibrin thrombi, and maybe clinically vesicopustule formation. And there's a few specific examples where you might be able to see some histologic findings that might point you more in a specific diagnostic direction. And those specific cases are, this is one example, this is a Pseudomonas septicemia. And these patients tend to be burn patients or patients with leukemia, and they tend to present with ulcers with hemorrhagic borders. And you see a necrotizing vasculitis and bacilli in the vessels. So in this case, from low power, we can see that there's a dermal-epidermal separation and quite a bit of hemorrhage from low power. And when we zoom in here, we can see that the epidermis is necrotic and that this was an acute process. So the stratum corneum is intact. And then beneath that, we have necrosis of the epidermis, and it's become detached from the underlying epidermis, or sorry, the underlying dermis, with quite a bit of hemorrhage here. And that there are fibrin thrombi within these vessels. So all this pink material here is fibrin. And everything kind of has this ghost-like appearance where there's an outline of pallor. You can no longer see the endothelial cell linings. The structures of the dermis here, you can't really make anything out because everything is kind of dead. So the fat here has a ghost-like appearance because everything is dead or dying. And again, here in this material, you can see that there are thrombi and quite a bit of extensive hemorrhage. So within the vessels, you can get a sense here of some bluish granular material at the periphery of these fibrin thrombi. And that's an example of the gram-negative bacilli that you will see with Pseudomonas. And again, typically in burn patients or in leukemia patients. And then another specific example of acute septicemia that may have some clinical clues as far as an etiology would be Vibrio vulnificans, which typically presents after consuming raw seafood, especially in patients with a background of cirrhosis. And they can present with bluish plaques and bullae that are non-inflammatory due to the exfoliative toxin of the Vibrio organism. And that's a gram-negative rod with a flagellum that you would see again at the periphery of these thrombi and areas of fibrin within the vessels. All right, so our next case, we're moving to a different body site, and here we can see that we're on an acral surface. And from low power, we are in the granulomatous category. And just speaking of granulomas, there's a few different types. So we tend to have our sarcoidal granulomas, which are more the tight and kind of naked granulomas. They don't have much surrounding lymphocytic inflammation. Foreign body granulomas, caseating or necrobiotic granulomas, palisading granulomas, and then calcified granulomas. And in this case, we can see that there are some areas of neutrophilic inflammation centrally And then here we have some necrosis. So this is an example of a caseating or necrobiotic granuloma with some surrounding lymphocytic inflammation. And when we see that, our differential diagnosis is a deep fungal infection, including an atypical mycobacterial infection, traumatic or factitial processes. So those are the types of things we think of when we see this pattern of inflammation. And when we see an acral sample, one of the first things I would think of is, does this person have a fish tank? Could this be marinum? So usually our next foray would be to get some bug stains. So when we're looking at mycobacteria, they are weakly gram positive. And as the name implies, or they're acid fast bacilli, so they're acid fast. You can also stain them for Zeal-Nielsen. And then the fight stain is better for leprosy. And we also have immunoperoxidase stains now for leprosy. So the highest yield areas to look for when you're looking for mycobacteria are in the areas of necrosis, in the areas of separative inflammation, so in the abscesses, and around the vessels. So we can take a look here at the fight stain. Let me just get that pulled up and I will show you the stain. So I apologize, our fight stain is not working. So this is a representative mycobacterial fight stain. But these are what the organisms look like. So they're these slender, delicate, rod-like structures. And typically where you're going to see them are in the areas of more inflammation. And they tend to cluster together, or you'll see them in these kind of filamentous singular structures. So thin and delicate, and they're relatively small, but your highest bang for the buck is to look in the areas of neutrophilic inflammation or where you have more granulomas. And they're usually relatively abundant in those areas. So fairly easy to see once you know what you're looking for. As far as mycobacterial infections, the types of mycobacterial infections that we see, we do see some TB still either direct inoculation or hematogenous spread, direct extension from underlying lymph nodes, especially in patients who are immigrating from other areas or who have traveled, especially immunocompromised patients. And then atypical mycobacteria will present with a similar appearance with the fight stain. And with those, we can see rapid growers, which are the CAF, the colonii, abscessans, and fortuitum, or the slower growers. And those we typically tend to see fewer organisms versus your ordinary tuberculosis. And that includes M. marinin, M. ulcerans, BCG, which is Mycobacterium tuberculosis, and for those you can culture, but you cannot culture M. leprae. And you'll see a similar granulomatous and neutrophilic inflammatory infiltrates, plus or minus epidermal hyperplasia with that. All right, in this next case, we have a punch biopsy that's divided, and the epidermis is really unaffected. And in the dermis, we have kind of a superficial and deep inflammatory infiltrate that is composed of these pale collections of cells with maybe a little bit of sparing of the superficial dermis here. So maybe a hint of a Grenz zone, but perhaps not as well defined as what you might see in G. faciale. You can see that there are these pale collections of cells that have somewhat histiocytic nuclei on these pale vesicular areas. And there are some vague interstitial, almost GA-like or DF-like areas at the periphery, but then they're also extending along adnexal structures and kind of tracking along the eccrine coils and even around the vascular spaces in the nerves, deeper down in the dermis. And admixed with those histiocytic cells, we also see a fair number of plasma cells. So lymphocytes, histiocytes, plasma cells with some vertically tracking areas. And when we go up to higher power and we look at these histiocytic areas, in the bluish areas, we also see these clear cells with this kind of hazy blue material. And these are examples of globi. So these are histiocytes that are just full of these little organisms. And this is an example of lepromatous leprosy. And this is the type of leprosy that you tend to see in patients who have a lower immune response, so more of a Th2 immune response. And these are the cases where you see many, many organisms. So in leprosy, we have either the tuberculoid type of leprosy, which tends to have a very strong immune response, and those tend to be the hypopigmented and anesthetic lesions that histologically look much more sarcoidal, so tight granulomas with tracking along nerves and very few organisms, in contrast to this type of leprosy, which is much more diffuse with more loosely organized granulomas in a sheet-like configuration with these very frothy histiocytes. So this is the multibacillary form. And let me get the phyte stain pulled. All right, so this is the phyte stain for this case. And you can see here that there are these very numerous organisms. So all of these slender pink structures are organisms that are just filling up all of these histiocytes. So everywhere that we saw these pale foamy areas are just filled with many, many of these bacilli. So this is an example of lepromatous leprosy. And we do see this in the United States. So more often in Texas and Arkansas, Louisiana, in patients that are exposed to armadillos, or even in cases where patients haven't touched armadillos, but maybe have been exposed to soil or had a traumatic implantation of soil and are immune compromised or perhaps older where they have not as strong of an immune response, they can develop lesions of leprosy. Also more common, not in the US, but outside of the US in India and in other parts of the world. And these do stain with phyte, also weakly acid or weakly gram positive, and stain with Zell-Nielsen. So an example of lepromatous leprosy. And then I just have another here. So here's another example of lepromatous leprosy. And this is one from the U of M slide study set. So you can see from low power that it has that somewhat sparing of the epidermis here. And this is, sorry, from Michigan. So if you're not from Michigan. And again, you can see tracking along the adnexal structures in a somewhat vertical configuration, again, deeper along the perieccrine structures and around the vessels. And if you go up to higher power, often you'll see a few plasma cells scattered around here, but you can see these pale areas with this fluffy kind of bluish material. And if we look at the phyte stain, again, you can see many, many organisms in here. So lots and lots of organisms. And they've also been described in this sort of sheaves of wheat configuration. So all kind of clustered together here within these Virchow cells. All right, and then lastly, from this chapter, we have a nodular vascular proliferation here and a patient who looks to be older. So we've got sun-damaged skin here and a little maybe basilar squamous atypia off to the side. But really what catches your eye are these large dilated vascular spaces and hemorrhage and a little lymphocytic inflammation, maybe even some vessels that have somewhat of a staghorn configuration. And centrally, as we zoom in here, you can see these large vessels with swollen endothelial cells and even maybe some um, random enlargement of the endothelial cells and some neutrophilic inflammation. But as we get even closer, you start to see some of this hazy material. So these kind of hazy bluish collections or these globs kind of in between the vessels. And this is really the diagnostic gold here. So what you're looking for are these collections. And the clues to the diagnosis in what looks like a vascular proliferation is inflammation that's a little bit deeper than what you would expect for perhaps a pyogenic granuloma or capices, and maybe some scattered plasma cells. Some of this reactive endothelial atypia would be a clue to go up at higher power and check for these clusters. So these collections of grayish kind of blue material are the organisms. And this is an example of bacillary angiomatosis.
And this is a nodular vascular proliferation with neutrophils and granular material. And the granular material are degenerated gram-negative bacilli of B. cantana or B. henselae. They do stain with Warthin stari, but it's really not needed. And it's a reactive vascular proliferation with CAT exposure and immunosuppression. The differential diagnosis for this would be like Kaposi sarcoma, maybe a pyogenic granuloma, and always important to exclude epithelioid sarcoma. Definitely not common, but something that you wouldn't want to miss. So that's it for bacterial. I hope you guys have enjoyed this. This is obviously not exhaustive. There are many other entities that we haven't covered in this chapter, but that we just didn't have examples of. So I hope you've enjoyed this chapter. And if you have any questions, as always, please feel free to send a message. And just to show you where the U of M virtual slide box is, it's at pathology.med.umich.edu/slides. And if you want to search all of the collections, you can go here and type in your diagnosis, and they have many different slides that you can look at here, in addition to the resident study set that we have. So this is a great resource to check out some other DermPath slides if you ever want to do that. All right, everyone, take care. Have a great week and happy 2021.